Hello, everybody, and welcome to today's session on seating for mobility management. We're so glad that you could join us. Virtually is where we're at still today in October, but we're so very fortunate that you could join us. Excited about today. We've got a pretty big day for us here. We're going to do probably the first hour and a half looking at what we're trying to do, how to do it, create a bit of an assessment process. Then we'll look at some products in terms of the seating that Jay offers. And then as a special guest appearance, we're going to have a client actually come in towards the end of the session and talk through, do a real pretend mat assessment and overall assessment for his wheelchair. Okay, so he'll be joining us later in the show, if you will. I'm Amy. I'm the clinical director here at Sunrise Medical. I'm broadcasting from Sydney to you over in WA primarily. Very happy that we could have this opportunity to be invited by UniCare. So Annette, hopefully I see that you're out there, self-muted. Oh, nope, taking yourself off. If you could say hello and give me a little bit of a sound check on myself as well. Am I broadcasting loud and clear?
Hi everyone, and hi Amy. I'd like to thank everyone for taking time out of their busy day today to join us for this webinar, and especially thank Amy for giving up her valuable time in trying to help us demystify both the scripting process but also the assessment process of our clients and individuals, and matching those needs with the products that are available from Sunrise Medical. So thanks so much, Amy.
Yeah, glad to do it. Annette, will you give just a little bit of an overview of what UniCare does, what products, and what you do at UniCare?
So I'm the occupational therapist at UniCare, responsible for clinical education and training, but also the scripting process at UniCare at present. UniCare doesn't do a full range of scripting. We are limited to the Quickie 2, the Quickie 2 Lite, the QXI and the Iris, and some of the Sunrise Medical Power Chair options. Our place in the scripted seating market lies with those moderate needs clients, and if we have somebody that requires more postural control than we can offer, or some more extensive control of their power chair, we tend to refer on, because we don't really have the technical expertise at UniCare to take you to that next level. So we'd like you to know that our scripting is really limited to those moderate needs clients, which I think we can fulfill quite well. And I think it's always really important for suppliers to recognise when they are reaching the limits of their expertise and be happy to refer on.
Absolutely. And moderate to more complex is a great place. That's probably where the majority of our clients are. So perfect.
I know we have some other suppliers who are logging on to this webinar as well. So I'd really encourage them to maybe present you with some questions and ask for a little bit more in-depth information from their perspective during the webinar, which may help you, Amy, with some extra information to present, because I can only imagine how difficult it is presenting from 9 a.m. till 3 p.m. West Australian time virtually, because you don't get a lot of feedback. So I would also encourage people to maybe present Amy with some questions and or comments, or even just anecdotal stuff on how you've used a Sunrise product and how it's worked for you, how it hasn't worked, and maybe what other help UniCare can offer from this seating perspective.
Yeah, and you can throw all that stuff in the chat box. We'll be taking, break at an hour and a half, sort of at probably 3 hours, something like that. So we realize that this is tricky to do via a computer screen, both on your side and on my side. So we'll be taking frequent breaks, and and taking a pause as we break for answering any of those questions. So please pop them in the chat box that you see on your GoToWebinar linkage there. Okay, and Annette, I guess we're doing pretty well on volume. All good?
Yes, all good. Yes,
okay.
Perfect.
Very good. Okay, so I'll just get started. I will have a couple of our clinical educators joining me sort of after we take that first break. And then again, towards the end of the session, we'll have a client coming in. So hopefully we'll make this virtually as great as we can. So to start off with, I guess we need to remember that this process is really the same, independent of complexity of your client or what type of chair that we're thinking about getting them. We need to create a list of what these clients want to do with their mobility device, in their mobility device. I think of ourselves as investigative reporters. You know, we need to tease out the details of these clients, whether it be someone that 6 months ago was you and I, healthy as you and I, and then he had a pretty aggressive stroke, pretty complex presentation here, lots of pain, but he wanted to get back to life and start moving again. Or whether it's a longer standing, this is a gentleman that's 10 years, 12 years post brain injury, and looking at whether we can increase his independence. So we need to figure out what these clients expect to do with their wheelchair. Where do they want to go? How far do they want to go? What do they anticipate doing in the wheelchair? I have a couple key sayings that I'm asking myself sort of rhetorically. What's most important most of the time for these clients? And what's the deal breaker? What is the most important thing that they have to have in this system? And you can't ask those questions directly. They need to be sort of teased out during the assessment process. But in the back of my head, I'm always like, right, what is this person going to do the majority of the time? What's most important to them most of the time? And are there key things that have to be in the system? Such as, does it have to have a low seat to floor height so that they can get into their already customized van? Do they have to be able to squeeze into their bathroom because that's an essential part of their day? Do they have to be able to get up a big ramp into their house and then turn around in that space? Okay, there may be multiple priorities, there may be multiple deal breakers, but if you can get sort of that list and then prioritize that list, while also considering their potential, what they might do if they had a better piece of equipment, you will be well on your way to creating a really successful mobility seating device for the client, sort of independent of their ability, their disability. Here's a client that's much more dependent. He spends all day in his tilt and space chair, but it needs to be comfortable for him. It needs to protect his skin. It needs to protect his ability to breathe and to swallow. Also needs to be user-friendly for all of his caregivers. I think many of us that have done tilt and space chairs in the past have seen that you know, this is about as much about the caregiver as it is about the end user. I'm just realizing that you may not have seen these two pictures that I was talking about. It should be good. Annette, can you let me know you see my screen, my pictures? You might have gone on mute. Or if we've got a very active individual.
Hi, Amy. Sorry. Yes, I can see your pictures.
Okay. Were they not showing before?
No, they're showing.
Okay, good, good, good. Okay, just making sure, part of the virtual process. You know, the more of these virtual things I do, the more I feel like I'm on Mars. You know, like this is what the future is when people are living in different places. Just want to make sure that we're all seeing the same thing. So thank you, Annette. If we've got a more active individual, you know, what does he anticipate needing to do in this chair? This is a good example when, you know, when he first got hurt, he was a young single man. But within 2-3 years, hey, his family expanded, he had a baby, there was, you know, his life changed. Did we make sure that his mobility device could adapt as his life changed? So when we start thinking about the process, we're gonna really look at it in a stepwise fashion. First is gonna be the client assessment or that evaluation. Think of it in both their functional status. What can they do? What do they need to be able to do? What do they need help with in terms of, pushing the chair, moving the chair? Is it independent? Is it assisted? Is it totally passive? How do they get in and out of the chair? How are they doing those transfers? What do they need to be doing while they're in the wheelchair? Okay. The physical aspects of it. What's their strength? What's their range of motion? In this physical portion, we may also look at their tone, their spasticity, any abnormal reflexes. Here we'll also do a very good postural assessment. We'll spend some time in that area as well. Client goals and their objectives. Again, what do they want this thing to do? What do they need it to do? From there, we can figure out, okay, what items, what parameters of the piece of equipment do we need? We need this low seat to floor height. We need this sort of width. We need it to accommodate a certain hip angle, right? All that sort of stuff. Okay, what do we need out of the piece of equipment? Then that will allow us to better dissect what piece of equipment might work. Hey, these 3 tilt and space chairs have those equipment parameters that I've said I need. Okay, these other tilt and space chairs, for example, they don't have those parameters, so I can exclude those from my list. Really what we're trying to do is get all this information, boil it down so that we can find sort of 2, 3 items, wheelchairs, seating systems, that'll probably best suit the client's needs. And so then we can go ahead and trial those pieces of equipment, right? But none of us want to have to trial 10, 15 different systems before we get a successful outcome. Okay, so if we can knock things out that aren't going to work, that aren't going to be appropriate before the simulation, everybody wins. More effective, more efficient, easier. Okay, then we'll do the simulation, the trial. And then this leads us to the actual prescription application for funding. And then, the last piece here is very important. We need to actually deliver, set up this piece of equipment, the seating system, make sure it all suits, make sure that the family, the caregivers, the end user, they all know how it works, why it's important. We give them some really nice training there. Okay. Then we've created a really successful outcome, or at least the potential to have the best outcome. What isn't on the slide is follow-up. Always good. Follow up that client. Hey, is this working out like we anticipated? Do we need to tweak a little bit? Or is it 100% ready, go? Okay. I always worry if I haven't heard from a client after I've delivered a new wheelchair. It's either perfect and nothing needs to be altered, changed, tweaked, or man, they haven't changed from their old piece, to the new one from their old because the old one they knew how that worked. This new one is a bit tricky. So just because we haven't heard anything from the client, don't assume that everything's good, okay? Do a nice follow-up just to make sure. Okay. Based on your investigative reporting, establish some goals. What do they need it to do? Go back to those key sayings. What's most important most of the time? What are the deal breakers? Once you've got that list of what we need it to do, prioritize the list. What's essential? And then work your way down there. I call that triaging as well, because as you know, these wheelchairs, we expect a lot out of them. We need them to work for the next 3 to 5 years. We need them to work inside, outside, at school, at work, right? And we need them to change and sort of accommodate as life changes. I always use the analogy, when I come to work, I wear my work shoes. When I go hiking in the woods, I wear my hiking boots. When I go for a run, I use my running shoes. These guys, they have one pair of shoes, and we need to have it work across all these different environments, across multiple years, and across multiple activities, even if things change. So we have to know what's okay to sort of compromise on. We have to know, prioritize our goals, see where we can wiggle a little bit. Yeah, I always think of what can I give to get? As long as I'm not giving away their key priorities, their must-haves, their deal breakers, I know that I can give a little bit on the less important, less prioritized aspects. Okay, we're going to do a full assessment. We're going to do the equipment trial. Based on all those steps, some of that goal prioritization may change. We may need to, we really thought the color purple was important, but it ends up not. We can give away the purple so that we can get our seat to floor height that we needed so that we can get into the van, okay? All of this works really well if you have information from the client, right? If you've done a good assessment, sort of tweaked out those details that are important to them. Then we can be comfortable in any compromise we need to make, and we can be confident in the application that we're putting in for funding because we're sure that we've ticked every box, we've crossed every T. And hopefully today's session is really going to be about creating a process for you guys to do that. Again, independent, whether it's a Breezy Basics chair, whether it's a highly individualized power wheelchair with all sorts of power seating on it. Process is really, really very similar. We also need it to be user-friendly. Okay, if it's too complicated, people are going to find ways to do it wrong or not use it appropriately. Okay, so make sure that's hitting what that family, that individual needs it to do. It's not too complicated, not too many steps. I always think that price can't be your first question, nor can it be your last. So make sure that you've considered least costly alternatives. When I'm writing a funding application, we create those goals, right? Based on probably their NDIS plan here. And then I'm always going to defend the least costly way to reach those goals. Maybe I'll say how this less costly, something that's very basic, it didn't meet those goals. Or something that's more expensive, hey, it didn't have these particular parameters. Or you could even say, if you've got sort of that middle of the road one below the highest cost, I tried this high one, but then I also tried this medium cost alternative, and hey, that hit my goals. Okay. Just remember, we do really have to say that this is priced appropriately, that we've really looked at using the least costly alternative to match their goals. Beyond that, we need it to last. Again, I think I said just a little while ago that we're really looking at a time frame of 3 to 5 years for wheelchairs, maybe 2 to 3 years for a seating system. At the end of the day, what we're really trying to do is create more function and more comfort in these systems. So really that's what I'm striving for. Have I been able to create a posture that's attainable, that's sustainable, yeah, that's comfortable? Within that posture, I have to think about function. Can they still do the stuff they want to do? I also have to think about, have I protected their skin? Okay. Promoting function based on their priority list. What do they want to do? What are they currently doing? What do they want to do? What do they expect to be able to do? And really what we'd like to aim for is that we're making the ability to move around their world, engage in their world a little bit easier. For some clients, that might just be being out of bed longer and safely and safe for them and their caregivers. For other clients, it'll be resuming a life they had before some sort of injury happened. They want to go back to work. They want to start driving again. They want to have the life they had before. Okay, so just look here. That's your North Star. We're really looking towards promoting more function than before they met us. We want to make sure that they're comfortable, that they can tolerate sitting in this thing, they can tolerate using it. And then, you know, as that backdrop, I've protected their skin. I've created a posture that will allow them to live a healthy life. Healthy skin, healthy breathing, healthy vital organs, that sort of thing. And at the end of the day, we know we've been successful when the client is actually using it and using it appropriately. Okay. Sometimes it seems like a lot, this process, but it really is pretty simple. Okay. Create more function, create more comfort, protect their skin, protect their breathing, their swallowing, their vital organs. Make sure that they have the ability to do the things that are very important to them. Okay, what do we need to gather in terms of assessment details? Okay, clinical factors, and I went through some of this just a bit ago, but I do want to just make sure that we're teasing out the details here. So if we're talking about a manual chair, how are they going to move it? Are they going to use it with their upper limbs, their lower limbs, one of each? They've had a stroke. Are they going to not push it at all? Is it just going to be passive? For a power chair, are they going to drive it? Are they going to use a joystick? Can they use a joystick sustainably? Can they, do they need some sort of alternate control? Again, is somebody else going to move this power wheelchair? The power wheelchair, you might also want to consider who's going to who's going to move the power seat functions. Okay, so how is this thing, how are they going to engage with this mobility device? Get a nice gauge of their upper limb strength, their lower limb strength, their trunk strength. Now, don't need to get really deep into this, but hey, can they move against gravity? What kind of strength do they have? Because again, we want to relate this all to how they might be moving this device. Okay. Same thing with range of motion. What's their active range of motion if you expect them to move the chair? What's their passive range of motion? Particularly at their hip joint, their knee joint, their ankle joint, their trunk, their spine, so that we can see what sort of posture that we can create. Do they have any orthopedic injuries, any orthopedic things that I need to consider? And then tone, within this tone category, I tend to think about it as a resting tone. Is it a low tone? Is it a high tone? Is this tone towards extension or is it towards flexion? Is there a rotatory component? Is their upper limb tone higher than their lower limb tone? Are they hemiplegic? Resting tone, okay? Then also spasticity, because remember spasticity is a little bit different in that it's movement dependent. So with movement, do they get spasticity? Again, what kind and where and how much? You can use the Asquith scale. You can use lots of scales to actually objectify that if you need it. But just know that spasticity is going to kick in with movement, might be different than their resting tone. Last part of this is any abnormal reflexes. And that's sort of position movement dependent, right? Do they have an ATNR, where they, with head movement, they get extension of an arm and flexion of an arm? Symmetric tonic neck reflex. With flexion of the head, they get flexion of the upper extremities and extension of the lower extremities. Do they have a tonic neck reflex? Do they have a positive supporting reaction? Do they have a startle reflex? If all of these are new terms, you haven't thought about it since you graduated, that's okay. Pick up on movement patterns and what triggers them. If when they put their head back that you get a bunch of sliding out of the chair, active sliding out of the chair, that's extension tone in that movement pattern. And you want to not have that sliding force in your wheelchair, okay? You can think of this thing as a sort of postural tendencies. Do they have a postural tendency going somewhere? Think about it as, is it high tone? Is it low tone? Is it towards flexion? Is it towards extension? Is it towards rotation? A lot of times it's going to be a combination of both. Okay. Here we're just figuring out where their body is likely to want to go, want to move to. Okay. Then we'll want to look at sort of their functional, how they're going to move around in the world. What kind of endurance do they have? For no mobility device, for the particular mobility device that you're thinking of. This might be really important in terms of your application and making sure that you can justify what level of equipment you're talking about. Do they have the endurance to do all the things that they want to do all day long, all week long? Sure, they might be able to push around the house in the morning, but by the evening they're so fatigued they have to go back to bed. Or do you have somebody that's a marginal wheelchair pusher? They can get some places in the morning, but by the end of the afternoon, they're dead tired and they can't do anything for the next couple days. Okay. Think about their endurance. Think about this particular mobility choice that impact on endurance. Their cardiopulmonary status. Do they have morbidities or comorbidities that might impact their cardiopulmonary, cardiorespiratory status? Do they have congestive heart failure? Do they have COPD? Do they have, a whole litany of things? They've had a heart attack in the past. Okay, how is that going to affect their ability to function in their world? How might it affect their ability to protect their skin from skin breakdown, from pressure injuries? Okay. And also its effect on their endurance, their ability to function in the shorter term and in the longer term. Think about how stable or how static their ability, their disability is. Do we anticipate any big change in their function? Increase or decrease? What does the next 2 to 3 to 5 years look like? And for a lot of these things, I like to know their primary diagnosis, because that's going to paint me a picture of what the future is likely to look like. I know somebody with MS that's a woman in her mid-50s. I know that she's most likely going to have an up-down sort of disability pattern. She'll feel pretty good. She won't feel very good. She'll have a recoup of functional status, and then she'll have a diminish of that functional status. Okay, and then, but the whole trajectory is really a downward progression, a worsening of her symptoms, a decrease in her overall function. I also know that MS lady that's in her 50s, she's probably more likely to gain width. She's probably more likely to gain weight. With a woman, she's more likely to gain weight at her hips. So I'll sort of build that into the idea as well. Okay, so based on their diagnosis, any comorbidities that they also have, think about how that's likely to affect their functional status, their overall size, their weight, even their ability to protect their skin, cardiopulmonary sort of status. Okay, and I know where you can't be 100% accurate, but looking at that diagnosis, looking at the comorbidities, will definitely give you a better guess, an educated guess about what the future might hold. Lots of other examples. SMA, I would imagine that that's a much quicker diminishment in functionality. If you have somebody with a new stroke or a spinal cord injury, okay, what does his family look like? When people come visit him in the hospital, are they bringing games and pushing him out to the park, or are they bringing Haagen-Dazs ice cream? You gotta, again, that's why it goes into that investigative reporting sort of idea. Tease out the details, the clues that are there, so that we can make better assumptions about what the future will hold. Okay. Lifestyle factors, where do they want to go? How far do they want to go? What's the littlest thing they need to get in between? What's the shortest thing they got to get into? What's the biggest obstacle? What obstacles are they going to run across? Okay. A lot of times when you're doing your home visit, you're going to pick up these things. You don't need to ask, you know, hey, what's the biggest incline you're going to come up to? You can ask them, you know, in more roundabout ways. Hey, where are you going to go? How are you going to use this? How far do you anticipate? What do you do on a daily basis? Okay, back to that investigative reporting sort of approach. Okay. Think about how they need to enter and exit. Think about how they're going to get in and out. Okay. Other part of this is, you know, they're going to give you this huge laundry list, at least some of them will. It's a huge laundry list of things that they need it to do. And you also need to ask, hey, how often do you need to do that? Because some of these things, oh, I only need to do that when I go visit my grandkids, and I do that twice a year. Okay, we're not going to put that on the top of the priority list because it's only 2 times a year versus how you get in and out of the house, how you get in and out of, you know, how you get to the doctor's appointment or how you use it every day is going to be obviously much more, happen much more frequently. Just a couple weeks ago, I had one of our dealers call me up and say, I need a power wheelchair that has lie down flat recline, has tilt, 136 sort of kilo weight capacity. But the chair itself, I think there were a couple other things in there too. Needed a pretty complex power wheelchair base because they had an incline that was very, very steep up to their house. Okay, I forget the exact gradient, but they kept saying it really needs it. We've got a huge steep driveway. However, they also needed to be able to transport this chair in like a modified SUV. So from memory, it had to be about 39 inches high. Sorry about the Imperial. About 39 inches overall height when the back was folded down, and couldn't weigh more than 120 kilos because that was the maximum capacity for the hoist thing that was going to put this chair into their SUV. And of course, they already had the SUV, right? I'm like, oh my, that thing doesn't exist. But then I started asking questions about, well, why do you need this? And why do you need that? And why do you need this? And truly, they needed the full flat recline because when they went to go get an x-ray, they didn't have the appropriate transport chair at the hospital. So the only way to get onto the x-ray table was via something supine. How many times does that happen? 2 or 3 times per year. Okay. And then, okay, but if you're, so that's one thing. I'm like, oh, does that really have to be in the equation? Because that was the only time they were going to use that full recline, which was really the weight barrier. I wasn't going to be able to get a chair with full recline under that weight capacity. Okay, so now I still have 2 big hurdles. One was the overall height, which was going to be a problem. Yeah, and also needed to know about this driveway thing. Okay, so they had competing issues. Hey, if we're driving your chair into the garage, do you absolutely have to drive up your big driveway? Or are you riding in the car and then you can get out and get into the garage? Okay, just one of those examples how we had to sort of go through, okay, what do you really want this thing to do? How often do you need it to do that? And are we willing to make compromises? Where can we make the compromise? That example is in a power chair, but I'm sure all of you would have 10 examples of that with a manual chair, tilt and space chair, okay? So first thing, get the list of what they want it to do. Why do they want it to do that? How often do they need it to do that thing? And then you can better prioritize, okay? And remember, this isn't our problem list, our priority list. We need to work in concert with them. So everybody's on page, everybody's buying into the solution, okay? And I know that I'm probably telling you guys all stuff you know, but sometimes it's just good to think through because it can seem complicated. You can be like, wow, how am I gonna fit all this stuff into just one wheelchair? Okay, which sort of leads me into transportation. I find that this is can sometimes be tricky. How are they going to transport it? Does the chair need to be folded and stowed somewhere in the car? How often? Who's going to do it? What's the capacity of that person? If it's the client that's using the chair, what's their strength? What's their range of motion like? How's their transfers? If it's a caregiver, a family member, same thing. What's their strength? How much are they able to do? Where are they anticipating putting it? If they're going to be riding in the chair while they're getting transported, make sure that it's crash tested. Make sure that the vehicle and the chair will work and it's either WC19 or ISO tested so that everybody can be happy and confident in the transportability of it. Okay. Also think about access. If they're riding in the car, how are they going to get into the car or the van? Who's going to tie it down? What are the space requirements? What are the height requirements? If they're traveling via public transportation, what kind of access? What are the needs there? Are there big gaps? Are there height restrictions? Are there width restrictions? Okay, just starting with how are we going to move around in our environment? And then obviously accurate measurements. Those of you that were with us in the last session, we did go through the measurements. We'll see how we go along the way here today. But in the handout section, we did include the measurement form. And I would really suggest that you try and use this or a similar measurement form. It helps you as you're getting ready for trial. You can send this to your supplier. You can say, I want a wheelchair, dynamic tilt in space. It needs to have these things, these equipment parameters. And my client's measurements are 16 inches wide, 18 inches deep, their back height, their elbow height, okay? So that they can bring out the appropriate piece of equipment to trial. So it just makes that simulation, again, more effective, more efficient, more successful. Okay. I have visitors. The assessment here, again, I think we've covered most of these. So the patient, the age, the weight, I call this sort of the demographics. Again, that's just gonna paint me a picture. He's bringing us demo equipment, that was very nice. It's gonna give us, sort of the idea of what to anticipate, gives us a picture of the future for this person. If they're 27 years old, are they 82 years old, right? And their weight, help me with the size. We talked about their diagnoses. Again, that's really gonna help us with painting a picture, their prognosis, and how they're likely to change. Are they likely to gain weight? Are they likely to lose weight? Are they likely to grow in height? Are they likely to grow in width? Think about those comorbidities. Some of these clients might be pretty complex. So we really want to focus on the comorbidities that are going to affect their skin integrity. So something that's going to reduce their ability to carry oxygen, protect their skin. Things that might cause seizures. Comorbidities that will change their shape and their size. Okay. Obviously, there's other considerations, but those are the big ones you want to think about in terms of they have a whole heap of comorbidities. Prioritize that list. I do very similar with their medications. Again, they might be on a whole host. I want to just prioritize what's important to me in this seating assessment. Generally speaking, that's going to be anti-seizure medications because I want to know if they are apt to have seizures. It's going to be cardiopulmonary medications, again, because that's going to affect their ability to carry oxygen around. I'll also want to think about medications that will change their size. Are they on a bunch of steroids that's going to make them increase weight? Are they on a bunch of chemo that's going to make them lose weight? I also want to think about medications that will change their shape. Most of these are going to be your spasticity medications. Baclofen pump, maybe Valium, any of those medications that's going to change how their muscles react, because that's going to affect their posture, their sitting posture, their shape. Okay, good. Special needs. This used to be an easier category. We needed to think about any sort of respiratory pulmonary stuff, like a suction machine, like a ventilator, like a CPAP machine. Okay. Maybe we needed to think about oxygen. Does that, do these things need to be attached onto the chair all the time? Just sometimes. GI equipment, suction machine, tube feed, those sorts of hydration, those things, do they need to be on the chair sometimes or all the time? Also think about any orthotic or maybe even a prosthetic. Okay. Are they going to wear the prosthetic, the orthotic all the time? Just sometimes? Because with an orthotic, that's going to increase their size, right? We need to leave space for the bracing. It also might change their shape, their posture. TLSO, like a body jacket. Okay, or second skin even, something that's a little bit more flexible than a true orthotic. Okay. If they've had a limb amputation, are they going to bring their leg with them? Do we need to consider that? Sometimes, all the time. Okay. So think about what they want to attach, what they need to bring onto the chair with them. But I think this category has even gotten a little bit more tricky in assistive technology that they want to bring along, like our phone, like a tablet. Okay, a lot of people want to have some way to attach their smartphone or their tablet. So how do we secure that? How do we make it reachable? How do we make it safe? How do we make it secure? How can that happen? Okay. Surgical history and future plans. I'm going to go back again. They might have lots of things that have happened in their past life. We want to consider the things that are going to alter their cardiovascular, their cardiopulmonary status, because that's going to affect their skin integrity, probably their endurance. We also want to think about anything that's going to change their size and their shape. So are they going to have back surgery? Are they going to have a muscle lengthening? Are they going to have a tendon release? Are they going to have a peg tube placed? Things that are going to change their posture, change their size, change their shape. Things that have happened in the past, also things that are being considered. I think we've talked a fair bit about their functional skills. You might want to separate this into two categories: things that they're currently doing, and then things that potentially they should be doing or could be doing if they had better assistive technology. And I think this is very important as kids get older, right? Or as kids become adults. If you compare them to their able-bodied counterparts, what would able-bodied kids be doing at their same age? Okay, so don't forget about the potential. Okay, we covered physical status before. There, it's just broken out a little bit. Remember tone, spasticity, abnormal reflexes. It's really important to get an idea of their sensation, their skin integrity. We'll do a little bit of that on the MAT assessment later on. Okay. Have they had any pressure injuries, any tissue injuries at all? Maybe not necessarily pressure. Where? Do they know how it came? What brought it about? Also, has it completely healed? Does it happen more than one time? Okay. Also, their sensation. Do they feel normally? Is it altered? Do they have pressure sense? Do they have light touch? Do they have hot, cold? We want to know for safety reasons, but also this is one of our key risk factors, isn't it, for skin integrity. So if they have altered sensation, we probably want to increase the protection that's offered in our wheelchair cushion and backrest. And then cognitive status. Also in this might be worth considering their behavior or their safety awareness and their safety awareness. Are they able to learn new things? Are they able to retain it? Can they apply it to new situations? Do we need to have things as simple as possible because they have some sort of cognitive impairment? And judgment, again, this is that safety awareness. Do they understand that stairs exist? Do they understand sort of spatial awareness, or can they learn spatial awareness? Some of these judgment, behavior, cognitive issues may shift me from thinking about a power wheelchair in a geriatric population to a power assist that's lighter weight, less damage, less risk of damage to both themselves and others. Or what, you know, they're so severely cognitively impaired that a power chair just isn't safe. Okay, so consider that. Same aspect in terms of visual limitations. Very good to know what they see, sort of approximately. Do they have any field cuts? Do they have a neglect where they are missing sort of one half of the field of vision? Do they have hemianopsia? So they're really only seeing the outsides and not the insides. Sometimes I feel kids with head positions like this, I wonder, man, do they have their head like that because that's they're horizontal? Okay, just make sure that you know about what they're seeing, what they may not be seeing, what their depth of vision is, again, so we can safely prescribe equipment. Again, that may alter your decision making between a power chair, a power assist, or a manual. Okay, it's not saying that some people that have field neglects can't use a power wheelchair. We just may need to use some strategies to make it safe for everyone. Okay, and you know, in this assessment process, we're just really trying to figure out, hey, what are the possibilities? What needs to immediately be knocked out of the running? And we're just really reducing the possibilities, reducing what we want to trial. That's what this assessment process is all about. Okay, I think I hit these as well. Endurance. Okay, remember, not only just now in this hour, but today, this afternoon, 2 days from now. Is it healthy long term? Is it sustainable? Can they do the things that they want to do? Are they having to sacrifice other activities just to move this wheelchair around? Functional skills. Make sure that you're considering the possibilities, the potential, what they could do, and those environmental considerations. Not only home, but all the places that they're likely to go, or they've listed that they want to go. School, work, family, church, all those other places. Where do they want to go? What kind of distances? What are the major roadblocks or hurdles? So we can best suggest some equipment. Okay. Again, also, hey, how often do you need to get through there? How often? Is there any other access place? Now here's an example. This is a really thin door. Okay. Do we need to get through there? The answer is yes. How often? Pretty often. What kind of modifications, easy modifications, could we make to the house? If this is sort of it, well, that's going to be our limitation, right? Here we've got a very, very, very steep ramp, and even worse than that, at the top, the platform up there is really skinny. So if they needed to turn around, they wouldn't be able to. Okay, is there another access? Do you need to get into your bathroom? Okay, what do you need to do in there? What activities do you do in there? How do you do it? Okay. And then these gutters that we have in Australia, these are great. Little wheelie bumps is what I call them. Okay. So look around their house, look around their environments. What obstacles, what fun obstacles are they going to come across? How can they manage them? How can their caregivers, their family help navigate them? I love this picture. Probably many of you have seen it before, but you know, what do they anticipate doing? I hope this is my future in lots of years, but except I don't want to be in the back. I want to be in the front deciding where we go, right? But you know, here we've got a scooter. It's sort of a medium duty scooter, right? Well, was it really built? Did they know when they prescribed this that we were going to be towing some significant weight on the back? Okay, so think about, people have stuff to do. And they're going to find a way to do it, whether we're talking about geriatrics or population, or we're talking about, 8-year-olds. What are they likely to want to be able to do in this chair? They'll find a way to do it, and you'll be surprised. Okay, so better that we know, so we can really make it built for purpose is what we're trying to do. Okay, and then you got to remember that the minute we sort it out, it's all going to change. Disabilities are events. If it's a new disability, it's an occurrence that happened. But on top of that, aging happens. Even if it isn't a progressive diagnosis disease, we just get old on top of it. So functionality is really going to diminish no matter who we're talking about, most likely. Okay, so we have to think about that aging needs to be built into the system. We also have to know that we change size, we change shape, we change what we do. We may change where we live. But again, if we do a nice assessment at the beginning, hopefully we'll pick up some clues that tell you what that next 2, 3, 5 years are likely to present or likely to happen. And then I also know that any prolonged sitting posture is pathological. We're not meant to sit, especially when we're talking 6, 8, 12 hours for some of these clients, okay? So realize that the longer that they sit, the worse that posture is going to be, okay? So we do need to compromise. We are going to have to make some decisions about, hey, how do I balance function and comfort and long-term good posture, sustainable posture? And you always know, or you can always sort of find your way back because you got that North Star. Their must-have is you got to create more function and more comfort while making sure that you don't have any skin breakdowns. And you're protecting their ability to breathe and to swallow and to poop, okay? So when we're starting to have to make decisions about what posture is good enough, that's your North Star. Have I protected the skin as best as I can? And you can protect the skin lots of different ways. Best way is to get out, get up, move. Okay, but if they can't get out of their chair, they're really in it for multiple hours a day. Well, have I given them a good way to do a pressure relief? And we know that a good pressure relief really is more than 30 degrees. Studies tell us it's more like 45 degrees, maybe even 50 degrees until I shift enough weight up of that bum and onto the back to give that bum a rest. Okay, so have I given them a good way to do a pressure relief, a position change? Okay. Number 2, have I protected that trunk such that they can breathe and they can swallow and they can eliminate? All that stuff in here, the vital organs, they need room to move, or room to be, really, okay? So if I have a really kyphotic and a very scoliotic posture, well, I know that my lung fields are going to be diminished. My lungs aren't going to work very well. I'm not going to be able to clear my secretions. I have an aspirational or a positional pneumonia build, okay? So have I protected their physiological function? Because there are going to have to be compromises, right? We just need to be confident in the compromises that we're offering, that we're suggesting. So really what we're trying to do in all of this is not create a perfect posture. We're trying to create attainable, so they can get there, easy enough, a sustainable posture, okay, where they can function and they can be comfortable, right, while they're protecting their skin and their physiological functioning. So good enough, right? And also, if we wanted to think about it, can I create that posture and then allow movement out of it but back into it? Remember, posture is dynamic. Position is very static. It's a shh, muscles, be quiet. A posture is sort of dynamic. It's muscles co-contracting, creating a very dynamic, one instant sort of place where the person is. But I want to be able to move from it. If I'm in a wheelchair and I'm pushing, I might have some really good posture, but then I'm going up a hill. I want to lean forward and push. But can I come back to that resting posture? Maybe I'm typing on a computer. I need to be more forward. I need to be more flexed. I do that, but then I can come back into my resting posture. Okay? So really that's what we're trying to do, is create a good enough resting posture, ability to move out of it for fine motor tasks, writing, eating, that sort of thing, and go back into your resting posture. That's good enough. And then movement out for gross motor movements. That's probably going to be moving a manual chair, pushing a manual chair, but then come back into that resting posture. Okay? That's really where the trick, where the magic is. What do they want to do? How long do they want to do it? And where do they want to do it? Okay. Again, you're not going to just ask those questions. You're going to tease out the information during your assessment process. And then you're going to prioritize. Okay, what's most important most of the time? What's absolutely essential in this system? Okay. In the efforts, here's your sort of aspirational goals. We always want them to be able to do more stuff than before they met us, and we want them to be comfortable doing it, both in terms of, sitting tolerance, man, they can tolerate sitting here, and a tolerance with the technology. I understand how this works. It's not too hard. It's not too complicated, and I'm willing to use it, willing to do it. Okay. And then underlining that, I gotta have my essentials. I gotta have skin integrity, and I've gotta protect that physiological functioning: breathing, swallowing, cardiovascular, digestive. Okay. Then the last piece of the puzzle here is I gotta have an eye on the future. So if I've let a little obliquity go, if I've let a little scoliosis go because it's promoting function and comfort, well, I just don't want it to look like a ginormous scoliosis in 5 years. Okay, so even if you're accommodating versus reducing any asymmetries, you gotta hold, you've gotta support it. You may not fix it, you may not change it, you may just hold that asymmetry, but you do have to hold it so that it doesn't get worse. Because remember, we're living on Earth in gravity. And a C curve, gravity is pushing, 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 so that in 5 years, it's gonna look like that. And then that is gonna impact skin integrity and physiological functioning, okay? Whether we're talking obliquity, scoliosis, or a frontal plane, a kyphosis, a forward head, okay? Think about its effects on down the road, and I wanna really prevent a worsening of those asymmetries. We know that prolonged sitting is bad for us. I called it pathological just a little bit again, because gravity is affecting us. When I start to sort of collapse in my postures, all of a sudden I have pressure in areas where I don't want it. I have increased shear forces, sliding forces. It's hard, I get bored, my muscles get tired. Remember that a lot of our back muscles, our neck muscles, those are meant to be short-term muscles, not static hold muscles. Okay, so muscles get tired, they get fatigued, they get overused. We also just get bored and we get lazy, okay? Which then leads to that collapsed posture, reducing how well my vital organs can work, and also putting me more at risk for skin integrity issues. Okay, so once we've done that sort of discussion with them, we need to then think about the actual physical assessments. We're going to break this up into a couple different steps, 3 different steps here. Number 1, if they're coming to see you, they've already had a wheelchair, look at their posture in that wheelchair. What do you like? What's perfect? Ooh, what do you not like? What do you not like a lot? Okay? What do you hate about that posture? Triage it, okay? You're going to build a problem list about what you like least about these postures. And what are you going to like least? The things that affect skin integrity and physiological functioning, decrease their ability to function, decrease their comfort. Okay, I'm going to sound like a broken record, but when you see some sort of complex postures, you're going to be able to go like, all right, okay, I got lots of competing motivations here and issues here. What's most important most of the time? Okay, so if they're coming to see you, what do you like? What do you not like about their posture? Take a look at the chair. Is it beat up? You got pieces missing, foam pieces missing. You got a year's worth of cat hair and all the casters. It's just going to give you an indication of how that chair, a new chair, will be used, most likely. Okay? Or is it pristine? It's brand new, right? It's all shined up. Either they take really good care of their equipment or they haven't been using it. Okay? Is one side all scratched up versus the other? Remember, you are investigative reporters. You're trying to figure out the history of this chair so that you repeat the good things, but you don't repeat the bad things. Okay? We really need to use the cues that are given to us. Okay? You want to create a problem list. Okay? What do we like least about this posture? Because I'm sort of giving this solo virtually, I get to give you my problem list, okay? Maybe you guys can all write it down at the same time. My biggest problem with this posture is the head position. He's got cerebral palsy. He's in his 20s. He's been using chairs his whole life. This chair is about 10 years old. It's time for replacement. Plus, his posture, this isn't sustainable, right? Okay, so problem list, head position. He's not able to swallow. He's not able to manage his secretions. He's not able to breathe. Okay? You and I know, hopefully, that the head is a symptom of stuff going on down below. Okay? When we're trying to solve a problem, we want to go for the actual cause, the root cause, not a symptom. Okay? So, but if we're looking at our problem list, number one, head position. Number two, hard to see from this picture, but he's quite extended. He's got high tone towards extension and a little bit of rotation, and he's sliding out of that chair. So he's got shear issues. Remember, shear is a risk factor for skin integrity. He's not stable. Everybody's having to reposition him. So it's a safety factor for both him and any of his carers. Plus the fact that we've broken rule number one, we haven't given him good physiological functioning in terms of breathing and swallowing. Okay. Also think about his postural tendency. Okay. Simplifying it, but is it high tone or is it a low tone problem? It's a high tone problem. Is it towards extension or is it towards flexion? It's towards extension. Okay. So what I want to do, the opposite. I want to see, hey, can I reduce his tone? Can I bring him more into flexion? When I do that, can I get the pelvis into a position where it is a stable foundation for a better position of his trunk so that I can put the head on top of it? Okay, that's what I'm sort of looking at. Here, we're just creating a priority list about what I want to change. Okay. There he is from the side. I'm just giving you another view. You can see how far back that head is. You can also look, his family has really done lots of stuff to try and alter this situation. He's got lots of pillows back there, lots of pillows. He slid out so far and they realize he's not getting any support from the chair that they stuffed stuff in there, okay? All of which is bringing him more into extension, feeding into that extension tone, feeding, feeding, feeding. We need to do the opposite, okay? However, we're only in step one. We still have to figure out whether it's possible to do all those things, okay? That's gonna be in step 2 and step 3. Okay. Just for, a comparison, we've got the opposite issue here. Now this is Chuck. He's a C6 quadriplegic times 10 years probably in these pictures. He has collapse. He has a low tone problem. He has a flexion problem. We create a problem list. My problem is lung expansion and by skin integrity, okay? Because he's so forward, because of his injury, even with an abdominal binder that he wears, his Buddha belly is forcing up, he's collapsed, it's forcing him up even more. His poor little diaphragm is not able to move hardly at all. So he really can't expand his lungs. He also doesn't have any abdominal muscles. So now my poor little lungs, everything's going to get clogged up in there. I don't have good lung expansion, and he can't clear secretions. This guy's cough sounds like this. Okay. We're setting him up for breaking number 1 rule again, physiological functioning. This is a great picture of somebody that's gonna have positional pneumonia, maybe even down the wrong tube, aspirational pneumonia. And in fact, indeed, that does happen to him. He spends a month in ICU. Anybody that knows this kind of guy goes into the ICU, he gets a pressure injury on his bottom while he's in the hospital, okay? Problem, expanded problem, expanded problem, okay? When what we need to do is we need to create a more neutral pelvis. We need to go towards extension. We need to offer more postural support. And we also probably definitely need power tilt, okay? To have gravity help us expand here, okay? They might actually have a picture, nope, don't. You know, if you get him into 30, 40, 50 degrees of tilt, all of a sudden gravity allows him to open up, increase that lung field, reduce the pressure on his bone, okay? Here, I find that this is a really typical muscular dystrophy, maybe even SMA sort of posture. He's very far forward, and we haven't given any support. This is a power wheelchair. He's really having trouble driving that power wheelchair. Okay, so can we find a postural stability point where he gets better access of his upper limb so that he can independently drive that power wheelchair? This, unfortunately, is a man with motor neuron disease, whose disease has progressed so rapidly that equipment hasn't caught up with him, hasn't gotten to him yet. But he's got sort of the limb girdle onset of motor neuron disease, so very rapidly losing head control, not able to manage his saliva, and his family is really all about, hey, we probably have a very short amount of time left with him. He's our loved one. We really just want him to be comfortable, get him out of bed and get him able to attend comfortably our family's activities, okay? We're breaking physiological functioning rule, and we're breaking comfort rule in this chair, okay? Obviously, our problem list is our chair is too short, seat depth is too short, our chair is too short, so it doesn't fit, and also it doesn't fit for purpose. This guy, there's no way he's gonna be able to do a position change, relief from gravity. We need something with dynamic seating for him, whether it be a manual chair or power chair. We've really got to create a comfortable place for him to sit for 4 hours, for 5 hours, however long he can tolerate being out of bed. Okay. And when I do that, then hopefully we'll be able to get better trunk control. We'll be able to get better head stability and control. Okay. So gentlemen, time for a new chair. This is actually a very interesting case where he's in it's a dynamic tilted space chair, living with his parents. You can see his mom, she makes really great cannolis, where we really want to fix this forward trunk position, sort of collapse. He's not gotten support from the wheelchair, so that's what he's learned. If he props on his arm, that'll just give him support. Okay, a mom in the past has had a chair that he could push around the house. He gets really agitated when things are happening behind him. And it's an Italian family. There's always people there. So he gets really agitated when he can't turn around and be part of it. So she wanted to go back to a wheelchair that he could push. He had one in the past, but he also needed dynamic tilt and space just for relief, for rest, and also for transfers. That's how they get him in and out of the chair. They use help with that dynamic tilt. Okay, so problem list. Number one, that posture. Can we get him upright sitting? Number two, this one's a little bit trickier. Can we give him inside short distances, more independent mobility while maintaining that dynamic tilt functionality? These legs, I'll tell you ahead, they are fixed in that posture. They just need to be supported and hold in that posture so it doesn't get worse. Okay. We'll see some of those after pictures, after we go through the assessment process. We'll see what we ended up doing with most of those guys. The last thing I want to talk about here before we go into the assessment process is, sometimes you're creating a posture in their wheelchair, in their mobility device that is good enough, but boy, longer term, are we going to be creating more problems? Like you're letting that little muscular dystrophy guy, sorry, I'll go back. You're letting this little muscular dystrophy guy come way far forward like this because that's where he gets stability. That's where he gets upper limb control. You're allowing that not great posture. Why is it not great? Well, because his hip flexors are going to get really tight because he's going to probably get into an anterior pelvic tilt and his back extensors are going to get tight. And just over time, is that posture can continue to sort of move forward and create more problems. Okay, so you've let something go in their mobile, in their seated posture, their daily posture, that boy, longer term you're worried about. Okay, whether it's this anterior sort of posture or it's an obliquity with a little bit of scoliosis. We got to remember that their wheelchair is this weird combination of both function and sustainable postures. Okay, that's when we might need to think about this idea. Their wheelchair has to be their mobility, their functional place. We might want to undo things that we've allowed in their mobility device in other places, other times during the day. This is what we sort of term as that 24-hour postural intervention. Can we use sleeping time? Can we use standing time? Can we use time out of their wheelchair to undo those postures that we're allowing in sitting? A paraplegic, as an example. I've put them in a ton of seat squeeze. Yeah, they're sitting in that seat squeeze for 12 hours a day. I'm worried that those hip flexors are going to get tight. I will look for somewhere out of that seating system to stretch those hip flexors. Easiest one for me probably is, can you sleep on your belly? Because then overnight I get those things stretched. Some guys can't sleep on their belly. Well, that's not going to work. Okay, can you watch TV for an hour outside of your wheelchair? Okay, if you're sitting, that boy with muscular dystrophy, he's really anterior. He's got some lumbar extension. Can I make sure that he sleeps a little bit the other way? I try and build in flexion into his seating system. Somebody that's had a pelvic rotation in their wheelchair, or my little Italian guy, he's got a ton of abduction, frog legging in his legs. When he sleeps, I can't have that same posture. Can I at least hold him there or give him a little bit of pressure towards the opposite direction? Okay, and that's what I mean is think about outside the wheelchair. Can you undo what you've let happen in the wheelchair for some of these more complicated postures? Okay, full-on sleep system, just pieces of a sleep system, a pillow, a stuffed animal, right? Whatever. Okay, just remember that the posture that the person is in the most is the posture that's going to win. Okay, use the clock. Use the hours that they don't spend in the wheelchair to undo things that you might have to worry a little bit about in their seated posture. You've got two options, really three. Another chair outside of the wheelchair. Sitting on the floor, lying on the floor, if that's possible for your client. Standing. Somebody is only a part-time wheelchair user, they're walking around, they're getting those muscle lengths other places. Or if they're a full-time wheelchair user, are they able to stand? Should you think about a standing table, a tilt table, exercise? And then the other one is sleep systems. Sleeping is probably the easiest to make the bigger change because they're in it longer. Hopefully people are getting 6 to 8 hours of sleep time. And we're also most relaxed. We're not fighting against muscle tone, okay? So that's what I mean by use the clock. Also, if you're looking at power wheelchairs, we use a lot of power seat functions in the same way. So this is, again, another girl, she's got SMA, but same idea. This is where she gets her stability. That's the posture that's functional for her. I'm never going to change that. But I worry that long-term her hip flexors are going to get really tight. Her lumbar extensors are going to get really tight. It might be hard in this picture, but she's got one leg crossed over the other. She's sitting. She does that for a couple reasons. One, it just creates stability and controls sort of floppy legs. And it also probably makes her feel very much more like a woman, like a feminine woman. All right, well, okay, if you're gonna sit like this, every hour, you gotta get out of that posture, you gotta tilt back, you gotta open up. You gotta stay there for a minute, 2 minutes, whatever. And then when you come back up into this posture, hey, can you switch legs? Okay, across this way, can you switch? Okay. I really do consider that wheelchairs and deciding on wheelchairs, sometimes it's like, hey, let's make a deal, right? You give me this, I get this. What's most important most of the time? What can I give to get? Okay. I didn't go into any of my background before. I've sort of forgotten, now I'm remembering, but I'm a physio and PT by background. And I've had a lot of experience in multiple places. And one of the places that's taught me probably the most is I took a wheelchair distribution trip to Mongolia. Really amazing. We had over 200 chairs that we were distributing. We basically flew to one end of Mongolia and then took a Russian truck all the way back and stopped along the way and fit and assess people for wheelchairs and then donated those, left them there. And I was out in the rural steppes. I was they have some more urban areas. I was there. You know, some of these places, they're just little roundabout huts. I'm thinking, oh my goodness, you know, when this child grows, is this wheelchair better than bed, right? Or if they try and stuff this kiddo into this chair in the next 5 years, is that going to be worse than just being in bed? You know, so going through all those decision makers, and that's really when I used my North Star, right? Okay, am I able to protect their skin? Am I able to protect their physiological function? Have I made everybody's life a little bit easier? And that's how I sort of decided. But my point in all this is about one of the last places. This poor little kid was about 6 years old, really complex cerebral palsy. And the mom had to work. She actually lived in a city and had a job where she went to an office. And the kid had to be by himself and nobody there until she came home at the end of the day. And he had a TV and they had electricity most of the day. So like any mom would do, that the best we can do, she puts kiddo lying on the side in front of the TV. But it was that TV, that direction every day, all day, for, you know, a couple of years at this point. So what was my intervention? Okay, on Tuesdays, head is nearest the TV. Yeah, but on Wednesdays, head is the other way. Okay, so at least he was getting a little bit of difference in the posture. There was nothing I was going to do about the fact that this kid was alone all day. That wasn't going to happen. Okay, what can I do with the resources available to me, with the knowledge? And it was really all about, hey, let's lie on the left side this day. Let's lay on the right side this day. Okay, so just make sure, let's make a deal. Okay, you can go back, and a lot of, thank God, our clients, it's not going to be that tricky 100% of the time, right? But it gets me back to the idea, okay, create your priority list, create your problem list, prioritize it, triage it. How do you do that? Comfort and function, physiological functioning, skin integrity. Okay, the rest is my art, is your art. Okay, really, those are the key bits there. Okay, just some ideas. Here's, he does a lot like this in his wheelchair. He's got a big wind sweep. Okay, if he sits like that in his wheelchair and then he sleeps like that, it's just going to get worse. I'm reinforcing that posture. So can we sort of undo what we're allowing in the wheelchair? Okay, and it can be, very sophisticated sleep systems, or it can be one pillow in between his legs, underneath his knees. Okay, use the clock. Okay, use the clock. Okay. I think I've hit all these. I live in the same world you do. This is sort of complicated. We never have enough time. We never have enough money. There's never enough resources. So remember that what people want to do is very individual. Okay, it's their priority list. We can always enable better decision making. We can at least try. Okay, aim to manage expectations about what this is going to do and maybe what it won't do. Realize that abandonment of equipment is real. It happens a lot. Some of the studies are telling us 20, 30%, maybe even higher. This equipment isn't used the way it's prescribed. Okay. One of the key ways to make sure that it's used is to be meeting the goals of the people that are going to use it. The client that's going to sit in it and their stakeholders. Okay, do they understand what it's meant to do? Do they buy into that? Are they accepting of that technology? If not, try again, right? During the assessment process. Hey, if you're just getting blank stares or no, don't force it. Because if you go ahead and do this thing because it's professionally a better best practice or better posture, it'll end up in the corner, right? Okay, so we've got to get buy-in from the people that are going to use it. Okay, but we gotta follow our North Star, right? Gotta follow those two rules. Protect the skin, protect the physiological functioning. But then remember that the minute we sort it out, everything changes. Okay, we're aging, we're growing. Tone and posture is very situation dependent. It's emotion dependent. Okay. Yep. And then back to the abandonment of the equipment. Really, lots of people are starting to do research on how we're missing the plot and how we're making mistakes. And really, even myself will start like, okay, totally inclusive of the client, but then all of a sudden I'm talking to the supplier and we have this one-on-one dialogue, like, wait a minute, let's shift off. Let's start using language that they can appreciate, that they can understand, and make sure that we're being as inclusive, as consultative as possible. Okay. They need to have a sense of they're part of the decision-making process so they can have buy-in. Okay. Okay. Just remember, we can enable them to make better decisions, but it's really important to have them feel like they're part of the process. And I've already said that 12 times. What's most important most of the time? What are the must-haves? This is the kicker picture. I love this one. Okay. We probably didn't know that this client was going to be using this as a way of carting her sister around. Okay. And she's been to Walmart. We'll blame United States of America. This is a USA picture. Okay. All of her Walmart shopping and her laundry. Okay. Remember, gotta figure out how this person anticipates using the piece of equipment. People got stuff to do, right? This is probably going to exceed the capabilities of this particular wheelchair. Okay, I'll leave it there. I love that picture. Okay, we're not going to talk a lot about wheelchairs today, but realize when we're trying to create that posture that we've decided we want on, it's going to be a lot about respecting where the body segments can go, either active range of motion or passive range of motion. We're going to use the seating system, the back cushion, the seat cushion to create shapes, contours, supports to hold the body in place, get the pelvis stable, get the back stable, keep it from sliding out. And then we're going to use some of the angles of the wheelchair, seat to back angle, front end angle, where the foot plate is, maybe even where it's located in space, its orientation space, to allow gravity to help us maintain or attain that posture. Okay, so it's going to be both the seating system, shapes, contours, and the angles and the overall size of the mobility base that's going to help us create that posture. Okay, so now we're getting towards that second step. What's available passively, actively? Start at the pelvis. The pelvis is the foundation. It's the causative factor. What happens at the pelvis will affect the trunk, will affect the head. A little bit vice versa too, right? But this is really the foundation, like your house. Can't build a house on a poor foundation. Look at your pelvis and look at the trunk. Look at their effects on one another. If you can de-obliquify the pelvis, but you get a bigger curve at the trunk, well, that's going to break my physiological functioning rule, right? I've just taken away space from the trunk. So make sure that you're looking at the impact on each other, and then make your decision, make your compromise if you need to. Make sure that you're looking at the pelvis, the trunk, its effect on spasticity, tone, abnormal reflexes. Look at its effect on comfort or discomfort. Remember, we want to be able to sit in this chair for a number of hours, most likely. Okay. We'll need to look at range of motions. Okay. Here's our muscle tone. We talked about that before. And then we'll need to look at particular ranges of motion. This is a seating wheelchair course, so we're most interested in looking at what kind of hip flexion we have. We'd love to have 90 degrees of hip flexion. Once we know how much hip flexion we have, hey, can I have that hip flexion with neutral abduction, adduction? Because I don't really want to have hip flexion at the sacrifice of a ton of frog legging, abduction, okay, or one of both. I want to consider that. I'd love to have neutral AB, adduction. Same thing with internal, external rotation. If I have foot flexion of 90 degrees, but it also causes 30 degrees of internal rotation, well, I don't want that, because if I have a bunch of internal rotation at my hip, now all of a sudden my foot's going to be all the way out to the side. Okay, so just see hip flexion, how does that alter AB, AD, and rotation of the hip joint. Keep the amount of hip flexion that you could get, and then you'll want to extend the knee, because that's going to tell you how long your hamstrings are. Remember that those hamstrings attach to the ischial tuberosity, and they attach down on the tibia, multiple locations, okay? So keep the hip in the amount of flexion that you need, extend the knee, okay? The minute you're pulling on that pelvic end of the hamstring, that's going to cause your pelvis to rotate, give you that slouchy posture. We don't want that. We just want to know, with our amount of hip flexion, how far out can the tibia be, okay? And then dorsiflexion. Remember that we have another two joint muscle there, your Achilles and your gastroc, that's what I'm looking for. Your gastroc is going to cross both the knee joint and the ankle joint. Okay, so make sure that you've got, you know, the amount of dorsiflexion that you have that, you know, in that ankle joint. Okay. While you're here, you'll also want to look at trunk position. Can you reduce scoliosis? Can you reduce a kyphosis? How do those body segments affect one another? Remember that we're going to do that supine assessment to figure out what's possible. Then you'll move them into sitting to figure out what's practical. Supine gives me their body without gravity's intervention, without gravity's effect. If you've got a complex posture where you got all sorts of asymmetries and you don't know what's going on, do a supine assessment. If you have a young kiddo and you know they're 5 years old, do a supine assessment, because we really need to be more concerned about symmetries in our young kiddos. If you've got an older person that's had a mild stroke or has early stages Parkinson's, they're only a part-time wheelchair user, or they're still walking a little bit, or less complex postures, start at the sitting. That sitting assessment, you'll be able to pick up easily what their ranges of motions are, how their pelvis moves, how their trunk moves, okay? So realize that it's not all the time that we need to do the supine, but for our more complex clients, it's important. It's a safer way to do it. It's a more effective, more efficient, more successful way to look at postures, what's possible to do, and then we can bring them into sitting. We know what's possible. Now, can we really do it with some foam pieces, some lateral pieces, whatever.